Welcome to our third panel of the day. In the wake of decades of divestment from social welfare spending, many urgent forms of care work are happening in unexpected places using ingenuity and resourcefulness. So our third panel of the day discusses how care happens in the margins from a range of perspectives, including disability justice, radical reproductive rights organizing, harm reduction, and social justice ministry. So it's my pleasure to introduce our panelists today. There's longer bios in your program, but to briefly introduce them. Laura Kaplan is the author of The Story of Jane, the legendary underground feminist abortion service. A lifelong activist, she was a lay midwife, an advocate for battered women and nursing home residents, and a member of Jane. Margaret Lowenstein is a practicing addiction medicine physician and an assistant professor at the University of Pennsylvania's Perelman School of Medicine. Dr. Lowenstein's research focuses on treatment and harm reduction interventions for substance abuse disorders. Laura Malden is a writer, professor, and 2024 New America National Fellow and professor at the University of Connecticut. She writes about ableism, the care crisis, and experiences and expertise of disabled people and caregivers. Her next book is titled Care Nation. The Reverend Canon Eva Suarez, is the canon for community engagement at the Cathedral of St. John the Divine. She received her Div from the Union Theological Seminary and MSW from CUNY Hunter. And moderating is our very own Center for Women's History, Saloni Bauman, who is our Mellon Foundation postdoctoral fellow in women's and public history here at New York Historical and one of the architects of today's conference. Her research explores histories of social welfare activism and care work during the first decades of the HIV/AIDS epidemic. Please join me in welcoming them.
Hi, everyone. Thank you all for being here, and big thank you to our audience as well. I think I speak for all of us at the Center for Women's History about how excited we are that so many of you have shown up to talk about care, and that so many of you care about care. We certainly think about it a lot, and each of our conversations today have been so rich. So extending a lot of gratitude for all the work it has taken to make today happen, including all of you being here, despite your own care obligations, which you certainly have. I am so pleased about this panel because it does bring together four people who work in very different kind of walks of life, but I think actually have a lot in common. So I'll reiterate some of Anna's comments. We have kind of representatives from the world of disability justice, radical feminist activism, social justice ministry, and harm reduction in medicine. And all of your work doesn't obviously speak to each other, and I've heard many rumblings that people are not sure exactly why they're on the panel. But I have a hunch that it's going to become very clear to all of us. And as I've been puzzling over it, I have been thinking that each of you do work at an intersection where you are talking about and thinking about care at once of the body, in a very material way, what it means to care for an aging or a disabled or a young body, hungry body, but also of the spirit and what it means to access care or access the world we live in with dignity and full self-determination or an idea of what each of our work means. So I have questions to begin with for each of you, and then I have a few that I'm going to pose to the group. And I'm going to begin with Laura Kaplan. And Laura's work is prolific, and for those of you who have not read The Story of Jane, I highly recommend it. But and for those of you who don't know, Jane was a group that was involved in providing abortion care before Roe v. Wade in Chicago. It was sort of an underground network, and I'll let Laura speak about it in more detail. But something I was really struck by while reading your book was about how you note that it was really important for the women that you provided care to or were organizing with to understand abortion as a political rather than just a medical issue. And that kind of this reframing was really central to the larger mission of Jane. And I was struck by the fact that that's in some ways very opposite to our current conversation around abortion or the political strategy around restoring the right to an abortion at a national level. And I wondered if you could talk a little bit about what your role was in understanding abortion as a political practice was at that time, and what sort of bringing in that analysis of feminism and politics to the work that you were doing allowed Jane to do more broadly.
Thanks. First of all, I think it's really important to understand that Jane was organized in the late 60s, and we folded after Roe v. Wade. So that was a very different time, and it was a very political time. And so many of us came from a political place. It was in our nature to see things in a political way. The other side of that is the woman who organized the group, Heather Booth, who's a pretty famous person, saw things in just that way. Given her work in Mississippi Summer, given her work as one of the really first feminist organizers of the women's liberation movement in the country. So she had a political lens, and when she organized this group, she wanted it to have that same lens. But it was really difficult for us to see our work in any other light because of the circumstances we were in. This was pre-Roe, abortion was illegal, women were forced to travel a really dangerous road to do what they felt they had to do. And they did, sometimes with terrible consequences and sometimes just with really unpleasant consequences. And so women all over the country, not just us in Chicago, determined to make that passage safer by sussing out the local underground abortion networks, finding the competent providers, raising money because illegal abortions were very, very expensive, and providing some kind of backup to women as they went through this experience. But Jane was different because within a couple of years, we had learned how to perform D&Cs and induced miscarriages ourselves. And from then on, we were an underground feminist abortion service. We never turned anyone away. We charged $100, but you paid what you could. Many women paid nothing or $10 or whatever. That didn't happen with any other group in the country, as far as I know, and I think I would know by now, so you'd think.
I love the kind of framing of the women's passage through that journey. I think that speaks to both the actual work you were doing and how much caring had to happen to set the scene. I'm going to move to Laura Malden, our two Lauras on this panel. And something I love about your work is that you really prompt us to think about the ingenuity and resilience that disabled people demonstrate when they kind of work with systems that are often hostile to their movement, to their ability to live their lives. And I noticed that in various projects that you've done, you were telling kind of a dual story. One about total state divestment, neglect, intransigence, and another about enormous creativity and how people have responded to those very harsh circumstances by kind of fashioning a new world of their own. I'm curious if you might talk a little bit about how you balance those two tensions when you think about care and, how you think about that.
Thank you so much, and I'm so glad to be here, and thanks to the New York Historical Society for having this event. Yes, so I have, sorry to make a plug, I have a website, disabilityathome.org, and it is a catalog, basically, of ingenious ways that disabled people have had to make home accessible and livable every day in the absence of, well, in the context of state abandonment. So if you have the Federal Housing Act, for example, has disability discrimination sort of in the updated law, However, that doesn't apply to residential homes. And so we have a less than 5% accessible housing stock in the US. And we have 25% of the adult population classified as disabled. And that includes chronic illnesses and things like that. And there's millions of falls each year, like in a bathroom. The bathroom's like the most dangerous place in the house. And people die and go to the emergency room, and it costs all kinds of money in the emergency department. But one of the things that I had done in this project that I just handed in my book on Friday, so I'm just like... yeah. But the book is chronicling both my experience as a caregiver, and I spoke with 44 different caregiver people who are spouses, and they're caring for their spouse. And I went and visited some and stayed with them and got to document, and everybody sent me photos. I have like hundreds and hundreds of photos of all the ways they rig up their home, right? The ways that they cheaply go down to the hardware store and put in grab bars, because grab bars are really expensive, right? There's all these ways in which the housing stock isn't designed for disabled bodies. And then people who are aging into care often, right, the bathroom again is a problem. And all of these kinds of ways that disabled folks who might be like spend most of their time in bed, and they rig up like their bed to have everything that they need. And set up, I had a person who used paint stirrers, those wooden paint stirrer sticks, to mediate between the lip of the garage floor to the kind of slight step down into the driveway, and so he had lined it with these paint sticks, because if he didn't, he would go flying out of his wheelchair. So there's like all of these really ingenious ways that people just use the tools that are just in their home to repurpose them in order to be able to make life accessible and livable on the day-to-day. So I'm really interested in those intimacies of what people are doing behind closed doors that we often don't get to see.
That's so interesting, and I will have a question for both Lauras very quickly. But Margaret, I wanted to turn to you a little bit. Your work is sort of clinically informed harm reduction work is one way I would talk about it. And I'm a historian of the first decades of the HIV/AIDS epidemic, kind of this moment where you see harm reduction take on a larger national profile, at least in this country. And during that era, it's often talked about as this really novel, marginal, dangerous thing that some people are proposing. And I'm wondering if you could tell us a little bit about how harm reduction currently lives in your work and how you see clinicians thinking about it, and perhaps even explain for those who don't know what harm reduction is.
Sure. Yes, I think you can hear me. Thank you so much for the invitation. This is a real treat to get to talk to this group, and usually I spend a lot of time with clinicians, so it's a very different experience for me. I think my experience and kind of background is really informed from the mainstream medical establishment. I went to medical school, I did residency, but equally important, I think, for me and my work has been getting the chance to practice as a physician within a harm reduction organization, housed in a syringe service program, and really being kind of pushed to think beyond the training that I had gotten in my medical education, which included very little on harm reduction. So I like to think of harm reduction in really two ways. One is kind of an ethos, like we, sort of respect meeting people where they are, kind of, and prioritizing the safety and well-being of people who use drugs, sort of regardless of their interest in quitting or continuing, and really kind of the preserving the dignity of people who use drugs, or other kind of risky behaviors that may be particularly stigmatized. I also think of it as a set of practical strategies like syringe exchange, like using naloxone or Narcan to reverse overdoses. We're hearing about in New York City, like say overdose prevention sites or safe injection sites. So some of them are very practical and some of it's more philosophical. And I think, within medicine, it's historically, really arose from, outside of medical establishment. It happened in, community organizations. It happened during the AIDS epidemic, or initial AIDS crisis, and often was sort of done illegally or by people who use drugs themselves or other marginalized groups. So again, I think we really owe that debt. Since then, it's been harm reduction practices have been well studied, and some of my work focuses on how we can sort of infuse the ethos of harm reduction, like welcoming non-judgmental care into more mainstream medical practice. But I still think we have a little bit of a ways to go. I think within mainstream medicine, we're seeing more we're seeing more acceptance of addiction or substance use as kind of a chronic disease or, a condition worthy of treatment. I think there's greater comfort with that. There's still like less comfort with the idea that people might continue to use drugs and that we might provide tools for them to use those drugs more safely. I think that is reflected. I did a survey within my own health system not that long ago where we asked doctors and nurses like, a series of questions, and more than 90% agreed that addiction was a treatable illness, that they felt comfortable with some of the medications for opioid use disorder, for example. But when you ask them about like how to refer people to syringe exchange or how to talk to people about safer use, was more like 20-30% felt comfortable with that. And so I think that we still have a long ways to go within addiction care. So much of medicine really is harm reduction broadly. I have lots of patients with diabetes who drink soda sometimes, or, we talk a lot about seatbelts, safer sex, all sorts of things that I think is much more part of the vocabulary of medicine. So really the work is kind of bringing drug use into the same frame as some of these other things and trying to make clinicians more comfortable addressing this, not just treatment, but really how people can be safe more broadly.
Thank you for that. And our final panelist, Reverend Ava Suarez. You are both an ordained Episcopal priest and a clinical social worker. And as we all met before this meeting, Ava shared with us that it's actually only been about 50 years since women could become ordained priests. And when I think about your career and your biography, so much of it has been at kind of this intersection between providing spiritual care and also really material care, like running feeding programs or clothing programs, meeting people where they are, accompanying them to end-of-life appointments, or seeing, being with them at the doctor's office, sitting with them in some cases. And I'm wondering if you could reflect a little bit on what being a female priest and what the change in the clergy, the gender change in the clergy, may have actually meant for what the job of being a priest has become, at least in your experience.
That's a great question. Thank you. I should just start with sort of a disclaimer that some of my answers on this panel will be very much about church broadly, and some will be, very much rooted in my experience as like a mainline Protestant priest, so I'm Episcopal, and in one of those historically wealthy, historically fancy brick, Gilded Age robber baron built churches. And so there are communities, like for example the Black church, where political engagement and mutual aid is very much part of the DNA of their experience of the Christian movement, and others where that's not part of the ethos or the thought at all, just to sort of put that out there. And so it's been almost 50 years of ordained ministry for women in the Episcopal Church. And at the same time, we've seen sort of massive divestment from social services. The church, for a long time, has been a place where people who otherwise fall through the cracks are found. For example, adults who are aging without supports. Their priest notices if they don't show up where they're supposed to be. We had a list at my last parish, notice if not in church on Sunday. So a lot of finding people who had fallen in the bathroom and trying to help them start to make changes in their lives, either reaching out to family members or, if they have no family, becoming that support system to come around them. And as well as, adults who have intellectual disabilities and other things that were less commonly diagnosed in an earlier generation, that meant that they don't really have a group of friends or a support system that they would otherwise have, but they do have a place at the church and so a community there. So a lot of people for many years have found their only community at the church, or the church has been the community that you turn to when something goes wrong that you can't tell anyone else. You're preparing for marriage and death, and all of those things happens with ritual, but then there's also sort of the day in, day out. I can tell this person, I can call this person to come to the hospital. I might not be able to call anyone else.
It strikes me that all of you are actually working on sort of radical information sharing in some ways, and communication, networking, kind of making connection or a safety net through information where none exists. And in particular, the two Lauras is who I had prepared this question for, but I think it will apply to all of you. You both, when I read Disabled at Home, it is a self-help guide as much as it is an intellectual, catalog. And the people you interview are so generous with the information that they have found about how to make Medicaid work for them, or how to phrase a claim so that it actually gets approved, or what vendors they use, things like that. Whereas Laura, one of the parts of other Laura, your book that I found so interesting were these power dynamics about how information about actually performing abortion came to be guarded, in part for safety, and also in other times just because of how institutions work or organizations work interpersonally with each other. And the two of you have just described kind of a series of practices that are really rooted in making sure that people are sharing information that is not traditionally flowing through a channel that it might be supposed to. So sharing information that your doctor might not tell you, or convincing a doctor to share a certain kind of information, or checking in. So I wonder, whoever wants to can start answering, but I wonder if we could reflect a little bit on how information and sort of the movement of that information factors into your research or your work, your experiences.
I can go. Because I had something, actually, listening to you, Ava, I was like, oh, I think this, and it dovetails exactly what you've asked. So I don't know if you're aware, but there was a disability rights movement in the US, right, starting in the late 60s, getting going in the 70s, and the narrative of that movement is culminated usually in the 1990 Americans with Disabilities Act. And then you have this sort of cliffhanger in terms of policy, in terms of state investments and things like that. Well, in the intervening years since the disability rights movement, there's something else emerging called the disability justice movement, which is quite different and emerging out of queer and disabled communities of color, folks who have always experienced state abandonment and have always collectively cared for each other in order to survive. Whereas the disability rights movement was largely white, middle class. I would just say it was classed in that way, although there were many racial issues during that period, but it was often not covered because some journalists thought that people were tired of hearing about the civil rights movement and didn't want to make the disability rights movement be a part of that, so they wanted it to be this sort of separate thing. Anyway, my point is that there's these disability justice communities and disabled people who have been doing this knowledge sharing and picking up where the state has left them. But at the same time, I think that, excuse me, there's something that happens with when I talk to people across the country, and I'm talking to caregivers and disabled folks, and I would tell you that most of them have no idea about disability justice. That's like an academic thing or an activist thing, but it's not characterizing the lives of everyday disabled people necessarily. And so a lot of the people I spoke with were sharing this information and telling me their ingenious hacks and stuff like this, and I'm like, this is like really cool, right? Like that we're gonna share this, right? And then caregivers talked to me about how they would have members from their church come and would show up and help clean up the yard, or take care of a bathroom renovation or something like this. And so part of what I write about in the book is this idea of collective care or mutual aid that is often identified, I think, with more radical leftist communities. And part of what I talk about in the book is like, it doesn't have to be weird. Like any of us can like collectively care for each other. It doesn't have to be a weird thing. You don't have to take on some new identity. And it can be, we've got a list of people in our parish and we're gonna show up, right? It can be this thing that we just do for each other without it being, overly precious, I guess, or turning into an identity.
Yeah, weighty or difficult to receive of like, oh no, I need something from the list. It's like we all know about the list. And, listening to you, I was so excited, like I can't wait to get home and share this list. Because clergy are asked to be generalists in a way that not many professions are. You really have to do a little bit of everything. Most clergy work alone because most places can only afford someone part-time or quarter-time, let alone multiple people to be a staff. So you're managing the boiler and whatever's going on with your congregation and leading a service on Sunday. And so with the growing number of women in the clergy. I think there's been a growing reliance on women as providing sort of social services and more intimate care in the home that they might not have been able to tell their priest before. So you've seen this very interesting drop in respect for clergy, money in the church, because you've also had a growing sort of secularism at the same time. So all the money that used to exist to provide for these services is now sort of drying up while there's more need than ever. Churches remain one of the safe places that people can go, and you have people who are generalists that don't know the information that they need. We don't learn about disability justice in seminary, needing to tap into networks that they might not otherwise know how to tap into. So there's this real need for information sharing, no real system by which information is shared, except there's a Facebook group for young Episcopal female clergy. There's 99 of us in the country. We're not all in the group, but most of us are there. And so it's things like that. And then also, a lot of churches are providing things like food, clothing. The cathedral has a hot food program, a food pantry, a clothing closet. There's no one list of all of these unofficial sites of provision. The city doesn't keep one, denominations don't keep them. So the people who actually know this, for the most part, are homeless and in need. So there's no list of all the food pantries in the city. There's no one list. So just a need to share information.
I was going to say that I feel sort of there's some echoes in what I do, because so much of what I've learned about the resources or sort of the practices has come from people who use drugs or people in the community, and I think that's something that I've tried to build into my research and my practice, and the group that I work with does that. But people keeping one another safe, people telling you where to get a hot meal, where you can get a shower, where, the supply is safer, where you can have somebody watch over you. So I think there's a lot of information sharing that happens in the community. We like to think in medical institutions that we know everything. And I think that's been one of the most humbling parts of doing this work, is really sort of learning that, wait a minute, I need to ask my patients. Also, I need to ask them sort of how they prefer to receive care, and that's not something we've historically done in addiction care. And so I think that's, something that's also important.
And that is such a starkly different vision of medical expertise than the kind of doctors you're often talking about, Laura Kaplan, in your book, who are sort of this very top-down 1960s, 1970s vision of institutionalized expertise that disregarded some things. And I'm wondering if you could talk a little bit about that, just your experiences with expertise.
Yeah, I think one of the things we found that we were doing was really challenging the medical establishment as we gained knowledge. Because back in those days, there wasn't any information. It wasn't like you could go into a bookstore and there was a whole wall of women's health books. There was nothing at all, until the birth control handbook out of Montreal, and then in 1970, Our Bodies, Ourselves. But before that, there was really nothing. So we needed to find out this information. Mostly, we learned a lot of it from the women who we got abortions for. They would tell us what their experience was, and we learned about abortion through them. And we had some doctor friends who would give us some information, but it was really wresting it from the powers that be. And certainly at the point at which we got involved in the abortions themselves and we took the tools into our own hands, there was, I always think it was like going through the looking glass or winding up in Oz, where suddenly everything's Technicolor. It looks totally different when you wrest expertise and power, and nobody was giving it. And I have to say that we've seen the medical profession evolve quite a bit, but still our experiences are generally, when you go to the doctor, you're required to give up power. You're required to become a patient. There are these drapes which they'll tell you sometimes that it's, so you don't feel violated. And I laugh. I say, especially if it's somebody who's got their fingers up me, I mean, what are you talking about? No, this is for you. Because clearly we're in this together, honey. The drape is to separate my body from me for you. And that's the same thing, I think, with medical knowledge, that it becomes, we control this. So things have gotten better, but I don't think they've really progressed to the place, at least I would like to see, where there's an equality in power. Because somebody's got a white coat on and they sit behind a desk, they automatically have all the power. Just like the teacher at the front of the classroom with the big desk. She or he has all the power. So we have to look at power dynamics in everything we do, and information is certainly key to power dynamics.
I'm thinking a little bit about sort of the physical infrastructure of care as I hear all of you talk, whether it's care or living at home, a space that's artificially excluded as a space where care can happen, compared to how many of the women you write about were receiving abortion care services in their homes, if there was no better place to be, or in fact that was a safer place to be in many cases. And when I think about both the church and harm reduction, it seems like it's sort of where the rubber hits the road of what is either most incendiary or most promising about each of those spaces, right? The church, we often think about this diminishing third space in American life, a place that people can go that is not their work or not their home, but in fact a place to just be. And I'm very cognizant of the ways that, whether it's safe injection sites or Narcan distribution centers or syringe exchange programs, where the physical place that kind of care is happening is often what's most controversial. This is an invitation to all of you, but I'm wondering if you could talk a little bit about how space and those distinctions of between spaces or controversies over physical space, why you think they do play out that way, and how it factors into your work, whether it's from a policy directive where space is sort of arbitrarily sectioned out, or if it's really kind of a controversial thing. There shall not be a harm reduction program on this corner. And perhaps, Margaret, we'll let you start.
Okay, yeah, that sounds good. I know there's a lot of controversy over the physical spaces where harm reduction happens. And I think, of course, a lot of this comes from the stigma that is associated with drug use and people who use drugs, and, how we've sort of criminalized and demonized them in society. I think with harm reduction, particularly practices, there's like worry that, it'll attract people who use drugs, or it'll make drug use sort of more popular. That's really been disproven. But I think there's real concerns about sort of NIMBYism, like, will this entrench drug use in our neighborhood? I think, the research has really shown that, things like syringe service program or overdose prevention sites actually, reduce public drug use, reduce litter. But I think people really have trouble kind of disconnecting these incredibly stigmatized behaviors from the physical space. We're going through this right now in Philadelphia. We have a new mayor, and there's a lot of efforts to kind of clear out the neighborhood where a lot of the most active public drug use happens. And there's real concerns from residents that shouldn't be sort of, not taken seriously. But it's interesting because I think then what happens often is substance use gets pushed into other spaces, whether it be the street corner, the subway, the church, the library, in the home, all of which are less safe, perhaps more public. Both for the individual and also probably for the community. And often, clergy or librarians or people like that are reversing overdoses who are not trained or sort of equipped to do that. I think some of the work that I've been involved in Philadelphia and colleagues do here in New York is really trying to flip some of that on its head and bring some of the services to the places where people spend time, because that we have created within our healthcare system a pretty unwelcoming environment. And often harm reduction facilities or some of these non-traditional settings are the places where people feel most comfortable. So it's a little bit of a flip dynamic, but the community opposition is often the biggest challenge to that. And solving stigma is sort of the $1 million question that we all are working on, but takes a lot of work and time.
Any thoughts on strategies that have been successful in solving stigma?
It's a good question. I don't want to take up too much time. We know sort of narrative and knowing a friend or family member is certainly associated with lower stigma, and sort of but I think sometimes the narratives get really wrapped up in sort of racialized narratives around what addiction is and how these crises happened. So I think seeing stories of people doing well, seeing stories of people in recovery, and sort of seeing examples of that has been one of the most effective things. And getting community buy-in kind of prior to establishing some of these sites, are there ways that we can, not do it in front of a school or sort of, engage the community before you just voice this thing in their community, which, may be viewed as very undesirable.
I think listening to you talk, I was also thinking that we live